we get to enjoy cataracts and all these other things. This is how arteries age. They fill with cholesterol. And cholesterol is not poison. We make it, right? So even if you never ate a source of cholesterol, if you never ate a cheeseburger or another piece of critter or milk, you would still make cholesterol. And that's part of your family history, is you have a certain level of cholesterol. And everybody talks about the good and the bad cholesterol. The good cholesterol is high-density lipoprotein, and that carries it to your liver and into your bile and out with your excrement. And the low-density lipoprotein, or the bad cholesterol, puts it right in your artery wall and creates an inflammatory process that obstructs your arteries. We all develop these pathologic changes. So when we say there's 10 million people with peripheral vascular disease, there's 300 million people in America that either have it or going to have it. And so as we age, and I'm the tail end of the baby boomers, so, you know, greatest generation ever. We're changing that now. Every generation claims that. And we're all in our atherosclerosis years, right? So in central New Hampshire, where I live, in Guilford and the Lakes region, the only demographic that's growing is retirees and people with blocked arteries. And they have the other healthcare needs of senior citizens, joint replacement, you know, urologist, you name it. But there's a huge demand for people with blocked arterial problems in cardiology, vascular surgery, and other stuff. So I put my thing down here. So let's talk about the pathologic changes. I don't mean to get all scientific and everything, but cholesterol is a normal molecule. We need it. It's the precursor molecule to testosterone and estrogen and other hormones, and it's an essential building block in your cell walls. It's an important lipid. So you have to have it. It just doesn't do that well when you have it for 40, 50, 60, 80 years. So that gets stuck in your artery wall. Your artery has three walls, a little thin layer cells called endothelial, very important cells that keep blood flowing smoothly and prevent clotting. Then there's some muscular cells that can squeeze and make your pipes change size. And then on the outside is the adventitia, which has all the strength. Well, the cholesterol gets under the endothelium and deposits itself in the smooth muscles and creates all kinds of havoc down there. What happens is, even if you look at the coronary arteries in troops from the Korean War, 19 and 20-year-old kids already had streaks of cholesterol, called fatty streaks, in their arteries. And so it starts in your 20s and 30s and progresses throughout. Then monocytes, which are some of your white blood cells, they'll migrate in there, they get hungry, they start eating this cholesterol, they say, this doesn't belong here, this is my job. They gorge themselves, they fill with bubbles of fat, and they form what are called foam cells. So this process of cellular migration and inflammation turns on the alarm for your body's inflammatory system. Now with the pandemic, everybody's heard the word cytokines, right? It's all over NPR and everywhere else, you know. Cytokines, from the root word cytocell, kinesiology, movement, cell movement, they're little cell messengers. And they're released by these cells to say, hey, we got a problem over here, and you bring in more humoral elements of inflammation, tumor necrosis factor, and interferon and interleukins and these things that create a little battle in your artery wall, and your artery gets upset, it swells, like a sprained ankle swells with inflammation, and then any injury, whether it's a torn hamstring or a swollen artery wall, will eventually get some hemorrhage. You get intraplaque hemorrhage, which makes it grow even faster, and then you get calcification, which is what happens to blood deposits. That's why we call it hardening of the arteries, because it gets hard and crunchy with calcium. Vessel wall thickening, stenosis, and calcification, intraplaque hemorrhage, I think we just covered that. This is what it looks like. This is a really busy slide I tried to steal from one of my buddies, and you know, you can tell I'm a low-tech guy, right? So, but let's focus our attention here on the side. This is a normal artery with 1, 2, 3 layers of blood cruising through. This is the fatty streak, and as it gets thicker, you have intermediate inflammation, the little cells eating, they look like foam cells, and eventually you get inflammation of fibrous plaque, and then this is the dangerous area. This is the plaque rupture. This is where the bad news happens. This is heart attack, acute limb emergency, sudden death, and blood flow to your intestine. That's an unstable event, and the way I explain it to my patients is, your body will tolerate some reduction of blood flow. You're just shutting down traffic through your interstate because you got all these back road arteries called collaterals that will carry the blood flow in the resting state. But when you put a demand on that, those country roads won't get the blood flow down there fast enough. The other thing the body doesn't tolerate is these big thick plaques can become unstable. Everybody in New England knows frost heaves. The bigger the frost heave, the more likely that's going to shatter into chunks of asphalt and debris, and some sand will build up in there. So we can get unstable plaque and what we call plaque rupture events, and that's what acute coronary syndrome is, or myocardial infarction, or transient ischemic attack when it breaks loose in your neck and goes to your brain or causes a stroke. So thickened plaques are more deadly. Guess I'm going backwards. It's the story of my life. Except when I came to Concord Hospital, it was the best move I ever made. Okay. So this is what it looks like in real life. Hope it doesn't make you lose your lunch. This is a blocked artery in the groin. This goes down to your knee and foot, and this one's supposed to feed your thigh muscle, and this is all yellow, cheesy cholesterol. Remember I said there's 3 layers to the artery. This blockage lives in the middle layer, and the outer layer has all the strength, so we can do this beautiful procedure where we cut your artery open and shell this out, like taking the nut out of the shell and lay a little patch on it, and that's called an endarterectomy. It happens quickly, it's less incisions and other stuff, and it's worth a Cadillac payment or 2 when you do it. So, this is the blocked artery going to your brain. This is the debris that builds up when a plaque hemorrhages, and this is a patient that had stroke-like symptoms that then resolved, and we took them to the operating room and we peeled this out of their carotid artery and neck. I know this is a leg talk, but I had a good picture of that. So how do folks present? Remember I said some people don't even know they have it because of the country roads, right? So as we age and we develop blockage, ladies tend to develop it up here from the belly button to the groin in their pelvis for some reason, and men tend to develop it in their thighs. In both places, there's pretty good country roads. So you can get a tight, narrow area, and if you're not walking that much or trying to, you don't have a dog that drags you around on the sidewalk or something, you may not even know it because you can just kind of shuffle and grocery shop and mosey, and it's not a problem. But as you put too much demand on that calf muscle and your interstate is narrowed or shut down, you can't get it through the country roads, you'll get a cramp in your calf. That's claudication. And all our brochures show people going like this, walking along and all that kind of stuff. And if it's a muscle bed that doesn't get blood flow, you get a Charlie horse. That Charlie horse in your heart is called angina or angina. In your leg, we call it claudication. If you block just one level, you may get no symptoms or claudication. If you block this level and partially block this level and additional levels, what we call multi-level peripheral vascular disease, then you'll get more devastating symptoms so that you may not even have enough blood flow at rest to keep your toes happy. And especially when you sleep at night and you lay down flat and you take that extra 10 millimeters of blood pressure that gravity helps get there, and it's out of the game, suddenly your foot aches, and people learn to hang their foot out of the bed at night, and we call that nighttime resting ischemia, or rest pain. And then if you get a little cut or a nick and your shoes are too tight, you bust them in new Jimmy Choos and they kind of put a blister on your shoe. I'm looking at you when I said that to you. So, then that area may not have enough blood flow to heal. The amount of blood flow it takes to maintain the integrity of skin is much less than the amount of blood flow it takes to heal a surgical incision or a wound or an amputation or a blister. So if you look at the natural history of claudication, we call that non-limb threatening people. We keep all answers in medicine easy for the medical students who can't remember that much, so everything's 80-20. If it happens a lot, it's 80%. Am I wrong, Rusty? It's like 80-20, everything. Or surface area is the answer to everything. So people who have leg cramps, 80% of them will live the rest of their life inconvenienced, but keeping their legs. And if they're smoking and we can get them to quit smoking, I can almost guarantee that they won't deteriorate. So that's why risk factor management, statins, aspirin, all the stuff we'll talk about later is so important. If you can intervene when the symptoms are early, you won't need an operation. The people who deteriorate are typically diabetics or smokers or smoking diabetics. If you're in the second category of critical limb ischemia, which is resting pain at night, open wounds, gangrene, this is the nasty stuff we talked about where 80% of patients will lose their legs from progressive gangrene or have to have a major limb amputation within 6 months. That's a big deal. That gets our attention. That'll get you to the angiogram suite or the operating room to have a revascularization. Acute limb ischemia we're not going to cover today. These are those emergencies where a clot from your heart breaks loose and sticks in your leg and you come in with a cold blue leg in 4 hours. We rush you to the operating room. I don't have time for that today. That's a whole nother hour talk. So we just discussed ischemic ulcers. It can either come from arteries slowly blocking and then they have one of these plaque ruptures or thrombotic events. We call that acute on chronic peripheral vascular disease with critical limb emergency. The other possibility is a big chunk of that cholesterol breaks loose and goes down south. So there's a difference between thrombosis, which is the problem clots, and thromboembolism, which is the clotting problem breaks loose and goes further down. So we need to sort those things out. But those are just the two pathologies. The word I don't like, anytime I get an audience, I got pet peeves. I got like 20 pet peeves. I'm going to drop one on you today. Okay? I'm going to take it easy on you. I don't want to talk about ace wraps or these other things that drive my life. You know how I do about that. Poor circulation is a vague and misleading term that should be avoided. So that's just a word I don't like because I'm a blood vessel professional. When the doctors from the emergency room call me or my colleagues say, I got this patient, they got poor circulation. I said, whoa. We all went to medical school. Tell me, is it arterial insufficiency? Do they have venous insufficient? Circulation is a big round thing. It's like a water pump cooling your engine block or your heat pump cooling your baseboard, putting heat through your baseboard heat. Goes out the arteries, across capillaries, up the veins, through the heart. It's a circulation. So let's be specific. That's all I'm going to do, except to say it can mean many things. For circulation, it could be a non-clinical phrase, which could be numerous problems. It could be arterial insufficiency, venous insufficiency. You could have lymphedema. You could have arteries that clamp down, spasm. Your heart could be failing. You could have decreased newspaper sales. Or if you're a surgical resident, you could have an inadequate social life. So there's so many things that are problematic. Usually start small. Most ulcers are precipitated by minor trauma. You know, I was just clipping grandma's toenails. You know, or I'm telling you, it doesn't happen. I just got these new shoes or something like that. And then this is how it ends up. So this is not a normal looking foot. That's pretty obvious. Let's focus on this one. This is not normal. This has all the signs of chronic ischemia. Ischemia is lack of blood flow, lack of oxygen. It ain't growing hair. The toenails are atrophic. The skin is dry. It's skin like a reptile. And so, you know, I'm about 5 or 10 years from my feet looking like this. But this little bump, which doesn't make, you know, people may look at that for 2 or 3 weeks at home and not recognize that that's the beginning of gangrenous tissue. It's more obvious when you go pay high dollar for this beautiful red pedicure and that gets cut tight and then your tissue turns dry. So the amount of blood flow it takes to maintain skin integrity if it's not traumatized is about 20% of normal blood flow. You need 30 to 50% to heal a wound once you develop it. So be careful, be careful, be careful. This has just caught my toe on the carpet and bent it backwards in a diabetic with blocked arteries. And this was a toe amputation performed by a non-vascular surgical colleague at another institution and got sent here because my toe amputation didn't heal. Yeah, did you happen to check pulses, homeboy? But that's okay. So what are the findings? You guys don't have to do a physical exam on yourselves or friends, but we see a loss of pulse, that's the first thing. The foot may be cold and mottled, alopecia, which means lack of hair growth, and then black dry ulcers. So when ulcers are up here weeping from a dog bite or swollen varicose veins, that's a different thing. Blood flow that's bad is going to cause problems at the very end of your feet, your toes and your heels, and without adequate blood flow, it's going to turn black and dry and look like beef jerky. Hope I didn't ruin beef jerky for anybody. And they're usually at a very distal location. So this is a surgeon's finest hour. We drain pus and debride dead tissue. If it's dead, it's never going to come back again, right? Put blood in beef jerky, it ain't never going to move again. So I tell the medical students, if it's dead, we should probably get it off because bacteria love to live on that, and there's an interface between dry gangrene, which is stuff that can last for months without bothering you, and wet gangrene, which is the stuff that in the John Wayne movies comes from the bullet of the arrow, and you don't make it to the end of the movie because you let it go up your leg. So wet gangrene can develop, which is bacterial infection at the dead living border, and it can be quite problematic, particularly if you have poor blood flow and diabetes. So when we see that, the first thing we say is, hey, this is a big problem. You need to come in a hospital. We're going to speed this whole process up. You know, now that we've got a cardiovascular center, we got all hands on deck. We can get you in. We can get that vascular lab testing right away. We can get the arteriogram right away. I can get you in front of 8 or 9 qualified colleagues to open your arteries if necessary. We don't like to start sticking needles in and operating right away. We do like to get a little test to quantify blood flow. So I can look at it and say, that's black, that's dead, that ain't going to make it. But I want to know how bad it is so that I can also check the results after you restore blood flow and have something to follow later in life. So it starts with draining pus to debride dead tissue. If they're infected, give antibiotics right away, get some non-invasive testing, and then move on to arteriograms and other forms of putting dye in your arteries to find the blockage and fix the blockage, either with stents, angioplasty, or some of the other stuff we're going to describe here in a second. I just stopped and breathe. So we already talked about the natural history. It's bad. Am I going backwards again? This is like a cool slide I also stole, but didn't come out that well. So it just says, if you have blocked arteries, things are bad. Just we'll trust those arrows to say it goes from left to right, things deteriorate, you need better blood flow. We want to get on to the cool pictures. An ankle brachial index, that is our most common. It's a simple test to be done in the family physician's office or the privacy of your own room, of your own home, if you happen to have all the equipment. You can check the blood pressure in your arm, and in the normal unblocked arteries, normal physiology, your blood pressure in your arm should equal the blood pressure in your ankle. They should be about the same. If you're standing, the ankle pressure may be a little higher. But this is our basic go-to test when we can't feel a pulse. We say, okay, I don't feel the pulse. There must be some blocked arteries. And knowing where the pulses end, I think it's either in the thigh or in the calf or someplace. I can identify the level, but I want to know how bad it is. How much blood flow do they have? Yeah. So this is a little worksheet we used to produce. Now it's all on a computer. It looks much cooler than that. But this is normal blood flow. So we measure the blood flow in the arm in the groin, in the thigh, in the calf, in the ankle, and we even have one that goes on your big toe. And this is normal blood flow called multiphasic. It goes, that's my sound effect for the day. And if you categorize these, it gives you some clinical indication of how that patient may do if you debride the dead tissue. If their blood pressure in the arms or ankles are 90%, if the ankle is 90% of the arm, or a ratio of 0.9, you're probably going to heal anything and you wouldn't have any symptoms. If your blood pressure, if you have a 0.5 to 0.9 means you're between the 50 and 90% blood flow in your ankle compared to your arm, you'll probably heal most wounds if we take good care of it. So in those people, we say, hey, we got your non-invasive test, your blood flow doesn't look that bad. We'll send you to the wound center, and our colleagues there will do good wound care and, take care of you, and we'll follow you closely and see if these things heal. If we see an ankle brachial index 0.3 to 0.5, meaning you're dealing with 30 to 50% of normal blood flow in your ankle, we get a little nervous. We say, well, we'll watch this, and if you're, maybe we get the next step, get an arteriogram, see if it's an easy fix or some great big operation we have to do, and then we'll have a week or two to follow the wound to make sure it's going in the right direction. If your blood pressure is less than 30% of normal, or an absolute pressure of less than 15 millimeters of mercury in your toe or ankle, you will not heal. So unless you want to be subjected to major limb amputation, we need to get the ball rolling and get you some better blood flow. I was tricky behind my back like that. I'm not going to bore you with how to perform this. You don't have to do it at home. I don't want you doing this in your garage and then suddenly we're out of business. No, I broke it. Treatment. This is what we all came to talk about. What kind of cool things can we do to you to get you better blood flow, right? Not you personally. You're just interested citizens, but if you knew somebody who had blind artery. So claudication, we already talked about. The natural history of claudication is that you won't lose your leg. You may have to slow your life down a little bit. And we have some things to do to slow the process, right? And we talked about those accelerators of risk factors. So the most important, and Dr. Meyer, my senior partner and very esteemed Concord colleague, is initiating a smoking cessation program through the Cardiovascular Institute with our other leadership, which is probably one of the most important programs that you can develop, whether you treat patients surgically or not. They all need to have the risk factors modified, and smoking cessation is most important. Antiplatelet means what we call blood thinners, aspirin and Plavix and other things that block the little blue cells called platelets that are the first thing to stick to a raw surface and cause a blood clot. So you don't want them sticking on your plaque, causing one of these plaque events and thromboembolism. And then the things that may make it walking better. And then statins are the drugs that lower the bad cholesterol so that you deposit less cholesterol in your wall. And then treat diabetes and hypertension and all that stuff we initiated in the cardiovascular center, and our cardiology colleagues are experts at it, and then they'll share that responsibility with family physicians. And also reassurance and education. If people know what they're up against, if they know they're not going to lose their leg, if they know they're not harming themselves when they walk. Look, if you got a herniated disc or you got a bad joint and you got there and say, I'm just going to fight through this, you just tear your joint up more and you herniate your disc more. But this is not damage. When you walk and your calf muscle gets tight, you just did a really big workout. And you may not be able to walk far enough or fast enough to make your heart beat fast to get any real cardiovascular exercise. But if your calf muscle gets tight, you've just stressed it. It's like going to the track and running wind sprints. So what we tell people, and this has been proven in evidence, if for 12 weeks, if you will walk for 20 minutes 4 times a week, you can triple your walking distance. That may let you do your grocery shopping, do the things you want to do in life, walk to your tea shop, whatever it is that's important to you, without having to have any procedures. If, however, the folks have already progressed, so we don't operate on people with claudication. There are conditions called disabling claudication, like if you're a 50-year-old factory worker or postal carrier, and you're going to lose your job and your pension and your livelihood because you can't walk, and you're willing to accept the risk of revascularization, we may talk to you about a stent or a bypass. The reason we just don't pass these things out, and I live and breathe to do procedures on arteries, that's why I walk the earth. But everything we do is like buying a set of tires. It's got a certain life, right? It's got a span. As soon as we cut, sew, clamp, or do anything to an artery, we upset that artery and we increase inflammation and we accelerate the blockage process. So we're getting short-term gains, but these are not durable procedures. So we save them like a ace up the sleeve for when it's really necessary to save legs. Now, critical limb ischemia, the stuff we talked about, breast pain and open ulcers, that takes something right away. If there's no ulcers, we try to get your CAT scans and your arteriogram and get you some blood flow the next week or two. And whether we can do that with catheters and wires and stents or with a bypass graft, which we'll discuss later. If you have tissue loss, We debride tissue, we already talked about this on the previous slide. Drain pus, give antibiotics, that gets you a ticket into the hospital. At least in my mind it does. Sometimes we get you a ticket in tomorrow or the next day, but I think I've learned forward from backwards on this. I am trainable. We already talked about treatment. Whether you get an operation or not, risk factor modification, smoking cessation, medical management with aspirin or equivalent, statins to lower cholesterol. Celestazol is a drug that came out to help people walk further. Everybody wants a pill instead of putting in that 12-week walking program, right? Well, the other thing we're putting in the Cardiovascular Institute too, in our cardiac rehab program, we're going to have a peripheral vascular rehab program. Krista probably knows this, or she's going to have us do it. Or I don't think I'm breaking news or anything about it, right? So that's in the plan. And that will help people if you show up and you have some friends going through the same problem. It may motivate you, whether it's weight loss or walking further or exercise. But Celestazol is a medication. Remember, we talked about those country roads. If your interstate's out and it's crunchy, hard, and filled with cholesterol, ain't nothing going to open that up unless a surgeon or an interventionalist goes in there and stretches it out or drills through it or something like that. But you can improve the flow through your country roads with blood vessel dilators. And Celestazol is a peripheral smooth muscle relaxant that dilates your blood vessels. And it's one of the few drugs that in studies, when you compare it to a sugar pill, increases walking distance about 40%. Woo, 40%. That sounds good, right? 40% off TJ Maxx, right? Who's not for that? 40% sounds good. If your mailbox is 150 feet away and you have to stop at 100 feet once to get there, go get your mail, come back and stop at 100 feet and get back to the house, if you can walk 40% further, you still have to stop once on the way to your mailbox. So 40% translation into the real world is not as exciting as it sounds, but it's sometimes just enough, and it's something you can do with the patients to let them know, hey, I feel your stress here, and that this is a bothersome situation. Let's try this medication and risk factor modification. And if you lose 20 pounds, that means that's 20 pounds like you don't have to carry around, and your calf muscle has to do less work. So it's all about supply and demand. And then in folks that have critical limb ischemia, open wounds, ulcers, we move on to some form of improving their blood flow. Endovascular revascularization is a technique in which you puncture arteries through little holes and go in with a bunch of gadgets and stretch them out, and we're going to see some pictures, and restore blood flow like that. Open operative revascularization is when big old mean surgeons like me show up and we make great big cuts in you and open you up and pull the plaque out, and we have a really good day, but you're having a bad week or two while you recover from that. And then there are hybrid revascularizations, which is some combination of some things can't be fixed with stents and too blocked to get through, so we cut down and fix that, but there's something upstream that can get a stent or downstream can get a stent. I did one of these operations yesterday, helping Dr. Duffy out with a patient. And so we use a combination of these techniques. So it's nice to have a lot of tools in your toolbox, and the more people you got in your cardiovascular family, interventional cardiologists, interventional radiologists, everybody has their strengths and weaknesses. Like cardiologists, they go through radial arteries to fix stuff all day long. That's not something I do frequently or ever. So if I need a case that needs to be approached that way, I got a room full of people right down the hall that can help me do that. Maybe they could come down my remote control for me. So this is the misery of my life. People come in with these gangrenous changes in their foot, and I have basically the same conversation with them every time. And I present it gently and compassionately with great understanding. You'll have to trust me, because it's a difficult thing when you're facing this and you don't know what you're up against. But these are the bad choices on the cardiovascular or peripheral vascular disease menu. You have this problem. I draw a lot of pictures. We look at CAT scans. You could choose, we always have to have informed consent and give people their options. You could choose no treatment. We'll give you pain medicine when it's suffering, and eventually you will die by gangrene, progressing in sepsis and blood poisoning. It's a slow, smelly, not pleasant death, but it can be managed just like managing cancer that's end stage or head injury that's end stage or any other thing. So this is always in the conversation. Most people get by that very quickly. Not always. Sometimes it's a very debilitated patient who may not be of sound mind, and they're in an institution, and you're having this conversation with their family, and this is a very peaceful way managed properly. So that's always on the menu. It's not why I'm around here, but it's on the menu, and we respect people's choices. The second is we could just find a level we think are going to heal. You've got a good pulse here, but no pulse behind your knee and no pulse in your foot, and your blood flow is 10% of normal, and you got gangrene ripping up your foot. We should probably perform an amputation and get you back in the game as soon as possible. These are the only two we offer people who are non-ambulatory. Sounds a little callous, but if you've already lost a leg and your life is wheelchairs or institution or a very loving family caring for you, and you don't walk, you're not going to walk without, you're not going to have a bypass on your remaining leg, which is lots of hours of work and risk of heart attack and multiple trips to the operating room, debridement and amputations, and you're still going to be wheelchair bound, we would encourage people to consider having a major limb amputation. We don't get there often. We do about 50 or 60 a year, which sounds like a big number, maybe not, but it's usually the final stop when your other procedures have been unsuccessful, but it is the appropriate first choice for certain people who are quite debilitated. But this is the space in which we mostly live and practice, is the revascularization world. And we already talked about open, where I cut you open, versus hybrid, where we cut you open and put in stents, and endovascular, we use stents and other techniques, with or without debridement and amputation. I don't even know what's on the next slide, so. Oh, once we decide you might be a candidate to get something fixed, you have to yell at me if I start going wrong here. I'm not almost done. But once we decide to get something fixed, those little blood pressure measurements at the ankle, they don't really tell me what's going on. That gives me an overall quantification of blood flow good or blood flow not so good. But I need a roadmap. I need to know what's blocked. I need to know how far it's blocked. I need to know where it opens up again. I need to know what your options are. So it used to be, to do this, we had to puncture a needle in your leg and go in and squirt a lot of dye that's bad for your kidneys, and that's how we found out. Now we have these glamorous techniques called CT angiography with high resolution CT scans, and images are beautiful. And this is what one looks like. This is a patient we operated on about 2 months ago. They have a small aneurysm here. So the gray stuff is the dye, the white stuff is the hardening of the arteries, that's the calcium deposits. These were completely occluded. This was completely occluded. And this patient had, you just can't see the artery here, it's out of plane. So this is slicing. You can put dye in somebody and put them through the CAT scanner. It takes x-rays in 360 degrees, and we put that information in a computer. Not me, but somebody who understands that. And we can slice you like a loaf of bread this way, or like this way, or slice it. And we can look at all these arteries and blockages and stents. This patient had an end atherectomy here. We cut down and pulled it out, went up through here. This aneurysm is not big enough to treat yet, so we put a stent graft through this aneurysm, and we put stents through this side and restored better blood flow to both sides, for 18 to 24 months. Like I said, it's like buying a set of tires. Easy solutions for less durable problems. So how do we figure out what's best for which patient, right? You don't just, not one size fits everybody. You just, it used to be like that. If you go to Billy Bob Stent Bar down in Ocala, Florida, and all he does is stents in his outpatient surgery center, because that's all he's licensed to do, he's not a surgeon, you're going to get a stent, right? If you're a hammer, every problem is a nail. So that's why you want to have a vast collection of colleagues and a vast collection of tools in your toolbox so that you can offer the patient what's best for them. So we make that decision individually for every patient. It's a fine balance. We weigh the procedural risk against the durability of procedure. In general, this is a general, older, more fragile patients, and when in the vascular surgery world, those of us in our 60s and 70s, that's not old, man. Old is like, you got to be 85, 88, 90 plus before we even consider the word old. But so older, more fragile patients are usually offered endovascular techniques, which are lower risk, less risk, no wounds, so no wound infection, less risk of heart attack, less blood loss, but we can't always achieve what we want, but so maybe we can achieve partial revascularization to make your pain go away and save your leg for a while. But these procedures lack durability. In general, stents, and they don't want to tell you this when we put them in, but the bigger the artery, they do pretty well. Big stents up in here, 90% of them are still open in 5 years. Down in here, less than half of them are open in a year and a half, and down here, less than half of them are open in a year and a half. We're working on better stents, ones that elute drugs, and the coronary artery has a similar path. It's not long lasting. You're buying a short-term gain. And sometimes my colleagues laugh and say, we're keeping people's legs on so they can die with both their boots on from some other problem. Hopefully shot by jealous lover or something exciting like that. But relatively younger patients are offered open procedures because they typically have a little better cardiopulmonary system. They'll tolerate the general anesthetics and the blood loss and the stress of the operation, which have a greater procedural risk but a longer recovery. This will get you 7-10 days in the hospital, then a rehab hospital, and come back for additional wound care and amputation, suture removal, and then physical therapy. I tell patients when they're looking at a big bypass graft in their leg, the first thing one does is, well, when do I get to go home? When can I go back to work? They don't ask that much, actually. It's a lot of people don't worry about it. But I tell them this is a 3-month process of operation, early recovery, maybe minor amputation, and then delayed recovery. you have to be honest, you have to be straightforward, and you have to help them manage their expectations, right? People come to me, come up, say, hey man, like somebody told me I had blocked arteries, my doctor couldn't feel a pulse, I can't walk to my tee shot, and I'm still smoking 2 packs a day and 100 pounds overweight, don't do any exercise, don't want to take a blood pressure medicine, don't want to control anything. It's injudicious to offer that patient an operation fraught with complications when you're not going to make their life a whole lot better if you don't change their lifestyle and help them manage the result. Nothing we do makes you an 18-year-old athlete again. What we do saves your legs so you can enjoy your life and bouncing your grandkids on your knee and all that kind of stuff. We'll skip this. Basically, there's a transatlantic inter-society consensus thing because when we compare results with folks in Europe and here and with different institutions, we have to have a language with which to say. Some people say, well, I put stents in 200 people and they all did great. We go, really? Did you get any follow-up on them? Well, no, I never heard from them again, so they all did great. No, they probably went to Brand X next door because their stent shut down and had to have a bypass graft. What we know is that you can stratify the likelihood of success based on the extent of the disease. The CAT scan that we showed with the aneurysm, you can see this stuff is not just 1 or 2 little spots. That's a dream world. This is all up and down your body like corroded pipes. We just have to get the worst problems and deal with them on an individual basis until we have a silver bullet button, a pill that just dissolves this stuff, right, which we do not. But so longer blockages have a higher, what we call transatlantic rating, and these are the people who you just can't get wires and stents through when they have this complete blockage. These are the arteries in the pelvis, and then this shows the artery in the thigh. So based on the length of lesion, how tight the lesion is, we kind of have an idea of which techniques might be the most applicable. But sometimes we just do what we have to do. I'm out of range. So what's endovascular revascularization? This is ideal for focal disease. In general, the bigger the artery, the shorter the blockage, the better the result and durability. It's generally less durable below the groin because these arteries are more flexible. You can't bend a stent, it doesn't like that, just like bending the roll inside of wrapping paper, it cramps and it doesn't come back to life normal. Smaller arteries develop more inflammation and there's a smaller channel that more easily re-occludes with thickening. And then smaller arteries below the knee, they have much limited durability, although we still use them. The easiest is, and the first used, was balloon angioplasty. Put a wire through the partial blockage, blow up the balloon, stretch out the artery, home run. Maybe it lasts 6 months, maybe it lasts 18 months. We can deliver, so that inflammatory process can be retarded. Just like you can retard cancer cell growth with chemotherapy, you can put a drug on that artery wall or a drug on your stent, and you can prevent the inflammatory response and smooth muscle hypertrophy that creates a recurrent blockage called neointimal hyperplasia. So instead of a $400 or $800 balloon to just stretch it out, we can blow up a balloon for 3 minutes that transfers drug that stays there for the first 3 to 6 months to prevent that from coming back. Those are called drug-coated balloon angioplasties. 80% of them are still open in 2 years. It's a great technique, but they don't give them away. Those are about $1,700 balloons, so we use that judiciously in patients that have proven to have early recurrences. Atherectomy devices sounds really cool. That's the roto-rooter. That's what everybody in the lay world thinks we do with arteries. We drill through them like John Henry and it's a great world, right? So it doesn't quite work like that. Because remember, every time you cut, sew, clamp, pinch, suture an artery, it gets aggravated and creates more inflammation. So you think about your escalation of force. If you got this artery that blocks due to irritation and inflammation, we're going to blow it up with a balloon. Well, that doesn't make it happy. Well, when that doesn't hold it back, we put a metal sleeve called a stent and we push it even harder. Because now we've added a foreign body. Well, that doesn't work, so now we're going to add a foreign body with chemotherapy on it, a cell poison. But for some reason, that's the path we've taken, and we're getting a little bit better results, but there's still no perfect world. And then we have stents and stent grafts, which are metal sleeves that can be expanded like those Chinese finger handcuffs and hold if there's physical recoil from the plaque, you can physically compress it out. And they're made out of metal called nitinol, which is a nickel titanium alloy that at body temperature exerts a constant radial force outwards. And you can line that with really slippery stuff called Gore-Tex or PTFE, which is the same stuff that's in your Teflon skillets. It's a non-stick inert chemical liner. This is what an angioplasty looks like. This is an arteriogram. This is dye coming down the artery here in the groin. This is the thigh muscle branch. The main artery is completely blocked. It's been bypassed with this vein graft, and it's got this little narrow area. I think I can convince you that's blocked. What you can't see is one of my colleagues got a wire through that. We were able to tickle it through there, these little wires, and you're pushing from the other groin up and over. We'll see a cartoon of that later. And once we get it in, believe me, this is a good result. This is a bad picture because I'm like Mr. Low-Tech, using my phone to take pictures of the computer screen. But this demonstrates the most basic angioplasty. Atherectomy, this is another slide I stole. But there are different types of atherectomy devices, and they work differently. So everybody wants a piece of this action. This is big money, man. So big pharma, healthcare programs, and device companies are looking for the best gadget. The earliest ones were a rotating burr. It's a diamond tip bullet that has a core in it, and you can drive it over your wire. And the first ones went over no wire. You just pushed and drilled, and it's like one of those pet eggs that rotates at 1,500 RPM. I've never used it. I'm kind of down on it. They put it in my mom's coronary artery in 1990, and it poked a hole in it, and she had to go have emergency heart surgery next door. So, not a big fan. Then there are ones that have rotating blades like propellers. There's some that have a side port that go in, and you put it down, and it keeps taking chunks, and then you rotate it, and it takes chunks here. That can cut through the wall, so they all have shortcomings. This can perforate or get jammed like a stuck drill bit. These blades can slice out through the wall. Those blades can slice out through the wall. This is electromagnetic fracture, which we have here. I think they have in the cath lab, where you can go in and you can send shock waves. So anything that's rigid can be cracked with sound, right? Or electromagnetic energy. An opera singer can sing and hit the right frequency and shatter a glass, so I'm told. I can't, it's not my range really to get up that. And so you can soften up a plaque that won't be stretched with the balloon, and then you can go back and stretch it. We have this, our cardiologists use this. These are, you have laser and other things that pulse light and fragment them, but these also can get off track because they don't go over a wire. This is the device we use here. It's called an orbital or crown orbital atherectomy device. I have a little cartoon. It's a spinning wire that's oblong shaped, and as it goes around, it kind of goes around, and it has a diamond burr, and I'll show you how it chews the plaque, and the faster we rotate it, the bigger hole it makes, and we use that to convince a calcified plaque that it's going to let us crack it open with a balloon. So in heavily calcified vessels, these drill devices or atherectomy devices are really some of the more suitable forms. Once again, it's creating arterial injury and aggravation and can limit your, I know I sound like Dr. Doom when I say that, I'm just trying to make Mr. Reality. So, oh, this is one of my moving slides. Hang on to your lunches, people. So this is an atherectomy after making an oblong path, but it gets better than this. This is the diamond surface, and they don't give these away either. I don't know, someone could probably tell me what they cost. I just use them at will when I need them. This is where it gets real high tech. I'm going to embed a video. Oh, I gotta have the internet on the background now. It's going to blow all pieces. Oh, let's see. Hopefully this brings up a YouTube of this device. Not like kittens doing stupid things. Okay, so I'm not on the internet. So, this is risky, man. This Nobody laugh at old guy doing computer tasks, please. Apply for a job in IT. One minute, maybe I'm claiming it too soon. Let's see how this works out. All right. I'm not going to narrate this. It's got its own sound if it comes up, and I'm going to scroll through it quickly because it's just. Here we go. This is the device we use here. So you can see it's oblong, this has the diamond, and there's a wire that goes, you first have to get a wire across any lesion to treat it, and they're thin like guitar strings, or even smaller, like thread. And they have some pushability and Teflon coated, and we put them through little catheters. Once we deliver it, the fragments that knock loose here go away. This shows how we puncture an artery. So they have all these cool names. This device is called the Diamondback, and the wire is called a Viper wire. I don't know who their marketing guy was. I don't know. If people are scared of snakes, it's probably a bad idea to start naming stuff like this. This shows the oblong thing, and this is like a dream world because it just went through like all these arteries really easily, and you didn't have to navigate like 17 blockages and put in stents just so you could reach the target artery. And anybody who has just one little lesion down here is not going to have any symptoms. So this is the company that sells the device. But it was it's a nice picture of how the device works. And we can push it over the wire, and you can see that it rotates. By increasing the speed, we put in this stuff called Viper Venom, more snake marketing, which has fat-based lipids as like a lubricant, like you would put in a drilling machine. And it has some blood thinner, and it has some vasodilator called nitroglycerin, so the artery doesn't get angry and squeeze. So we first go at low speed and we get an opening. If we get a large enough opening, we go ahead and put a balloon in and stretch this out. So this is typically not the only treatment. It's the treatment for calcified lesions. We don't deploy this in every patient. The one thing I want to show in the video, because everybody goes, well, what happens to all that stuff? Because these little things are the chunks, the dust that it knocks loose, which is smaller than your red blood cell and smaller than your white blood cell. So it passes through the capillary bed, and your reticular endothelial system or your white blood cells eat it up, or it's trapped in your spleen. So it causes no harm. Some of the other devices, those chunks break loose, and they have to do another operation in the foot and ankle because you've showered it. There was ones called the Turbo Hawk and the Silver Hawk, which were notorious for distal embolization. I can't take it anymore. All right. So that's the pinnacle of the gadget world. This is how it works in action. This is a blocked artery in the leg in a 93-year-old gentleman. Very, very hard. I was able to snake a wire through that. This was like 2 weeks ago. And this white kind of cast you see, these particular arteriograms are unique. They're called digital subtraction. What we do is, back in the day, we used to just take a regular x-ray and you'd see all the bones and everything and give a high concentrated dye so we could see it over the bones. But now we have these fancy computers that we take an x-ray, it subtracts everything that we just took, and then we put the dye in, which is really dilute, and it's the only new stuff in the picture, so that's all that shows up on the screen. Our new interventional suite has some of the state-of-the-art equipment to look at this stuff. So I was able to get a wire through it, and then I stretched it out with the balloon, and what you can't see here is that this is a stent. And once again, I'm kind of like a car salesman, but this is, not that there's anything bad if anybody's a car salesman, but this is the dye flowing through there smoothly. Operative revascularization. So if you're a vascular surgeon and you're the only guy with this tool in your tool chest, you probably think you're like the pinnacle of the world. But it turns out a lot of the gadget guys, our cardiologists, interventional radiologists can do a lot more wizardry than we can. And sometimes we're the de facto default guys when you just can't get a wire across. Everything that I do, cutting you open, carries a greater procedural risk. When there's a wound, there's a risk of wound infection. In the groin, there's a 20% or 1 in 5 chance. We only deploy this for people who have some function, to save a leg and someone who's still walking or you're going to utilize it. There's a 10 to 20% wound complication. 2 to 5% of people will have a complication such as major heart attack or death. So when patients come to me and they say, I want you to put a stent in or do my FemPop bypass so I can go back on enjoy retirement and run on the beach and play golf. And I'm like, are you willing to accept a 1 in 20 chance that you have a massive groin wound infection, you have to move muscle around your change for life, or 1 in 20 chance that you're going to die or lose your leg? So there's significant risk to these procedures. But most of the time, 95% of the time, we're successful saving limbs. They're generally more durable because we're putting in living tissue that's lined with endothelial cells, and we use one of your veins to replace your artery. We can also just clean it out and put a patch on it. We can take your own vein to do a bypass. We can do a bypass with artificial graft, cortex grafts. So I'm going to zoom through this so we can get to questions. This is the plaque that comes out. We shell it out. This is a patch, a biologic patch made from the heart sac of the cow. So when we cut a round artery and shell this out, if we just sewed it up, the seam would gather kind of like a baseball seam, and you'd have a narrower flow channel than you were born with. So when we lay a patch on it, it takes longer to sew down both sides, but we give you a bigger, more wide open artery that lasts longer. This is how people present sometimes with advanced dead tissue. The young diabetic patients are in their 40s, already lost one toe, now has blocked arteries, and this is how they come in sometimes. I didn't want to call you because I was just worried. I didn't want to have an operation. 3 days after admission, we do an open amputation here to get rid of the dead tissue, give antibiotics, go to do an arteriogram, find that she needs a bypass from her groin to the artery here above her ankle, and then complete her amputation 2 days later. So this looks brutal if you're not used to seeing this, but this is a leg that will still work in somebody who's at high risk for ongoing limb loss. So this is a patient who came in, she's 88. They couldn't get through with any wires or anything, and so we did a bypass from right behind her knee to this artery behind her ankle into the bottom of her foot, and we were able to take her gangrenous toe up. I just saw her last week. This was about a year ago, and she's walking around the house, doing the things she wants to do, shopping and enjoying life. It doesn't always go well. Sometimes our wounds break down, we get necrotic, and you end up with this big open wound, and this is an exposed bypass graft that takes months of muscle flap transfers and wound care. However, 95% of the time, one of these techniques is able to save a leg. As much as I've talked about the doom and gloom and limited durability. But it takes a system. If you just carved out the surgeons and the interventional colleagues working in isolation, we're just a bunch of procedure monkeys with expensive gadgets. And nothing special. It takes a system. It takes family doctors who recognize this problem, emergency room physicians and friends and family who recognize this problem, get them into the right office. It takes a system of schedulers and people who can do vascular lab testing and physicians and providers who will be present to be there. If it's properly applied, the surgeon can just become the critical cog in the machine that can save limbs. What we've achieved here is recognizing Concord Hospital, as many organizations around the world, have seen that this is a huge wave of problems coming. It's a huge wave. The year before I came here, this hospital did 312 vascular operations. The year since I've come, we've done 750. It's not because we have more people. These were people waiting to get this treatment in central New Hampshire because it's a growing problem that is being more and more recognized. Former practice models, they didn't care for this. You had this group over here and that group over there, and if the cardiologist couldn't help you, he sent you to the vascular surgeon, sent you to this. You got to wait 3 or 4 weeks for every appointment. There's no one-stop shopping. It'd be like if you're trying to feed Concord with a series of, really nice farmers markets. You just can't get everything you need in one stop. There's too much delay. There's too much expanse, and the supply is not good. It was fragmented. It was delayed, and multiple sites, multiple devices, multiple vendors, multiple budgets. It's just not efficient. It's not good for patient care. It's not good for the finances of the organization, and it's a lot of redundancy in a system that's already stressed with more patients than there are providers to take care of. So there's my farmer's market. I learned how to do clip art last night. So, so what Concord recognized is now a reality. There was the years before I came, there was enormous commitment from the community and the board to see this mission through. Administrators talked to consultants, they looked at the needs. We got a new chief clinical officer a couple years ago, Dr. Gibb, and we have our twin leadership with Dr. Newton and Chris Green, who run our Cardiovascular Institute. And it's been enthusiastically, I came in as the plane was taxiing down the runway. I moved my practice out of necessity. I had one partner quit and the other passed away from leukemia. So we went from a 3-surgeon practice to just me, and Dr. Meyer was gracious enough to find a home for my 1,000 patients to bring here to have a path forward in central New Hampshire, and it's worked out famously. But at that time, we were just developing this Cardiovascular Institute where we all become co-located. I got 2 more slides. 112 people now participate in our Cardiovascular Institute. We have 22 patient care coordinators, schedulers, and people who check you in and check you out and make sure you get what you need. 26 nurses, 13 medical assistants, 13 cardiologists, 3 interventional cardiologists doing stents and structural heart and valves, 4 advanced practitioners, PAs, and nurse practitioners working throughout the system, 3 interventional radiologists, 3 cardiovascular surgeons, 5 vascular surgeons. We've hired 2 new ones since I came to pick up the volume from the Suffolk Lakes region and the need of the community, and 8 administrative leaders. What we've achieved in the first year, We combine all the services in the new office suite. We share resources staff. We enhance access. It's easier to get an appointment. There's only one set of payroll, one set of call schedule, one set of everything instead of 7 different satellite offices. Once a month we meet to discuss interesting cases and have some academic ferment and share ideas. We just had it the other Tuesday night. It's great to listen to my colleagues and learn from newer, younger people of perspectives that I have not opened my eyes to through the years. We have an integrated clinic where you can come in and see an interventional radiologist, an interventional cardiologist, or a vascular surgeon in the same visit, so that we can decide whose services would be best to serve you, whether it's through the approach or stent or which size vessel. We've opened an additional advanced interventional suite with state-of-the-art equipment that just opened 2 weeks ago that they planned for about 2 years. We have the probably best one in New Hampshire now. We've doubled our cardiac surgical capabilities and went from one, Dr. Francelante, who was working himself silly. He now has 2 partners. Their 2 new cardiac ORs will be finished, I think, in the fall, Chris. I'm not quite sure when. And we've doubled that capability, and we've transitioned the vascular surgery practice from Lakes. We're at about 1,008 patients and patients who didn't know how they were going to get care anymore until, as that place was becoming derailed, and Concord Hospital has wrapped their arms around them, and we've been able to integrate their care here. And we still have 3 days a week full presence up there. We're seeing 12 to 16 people a day, 3 days a week, to make it convenient for them to still use their testing. And I think that's the end. Vascular surgery, saving the world one toe at a time.
Questions for Dr. Aldridge? No one has any questions for Dr. Aldridge? Oh my goodness. You
It was
must have
either
answered all the
overwhelming or
questions.
perfectly explained. One of those two.
Great job explaining, that's all.
Yeah, there we go.
Yeah.
I'll buy that. I'll buy that.
Thank you,
too.
Dr.
Yeah,
Aldridge.
thanks for
It
having
was
me.
a fabulous presentation. We thank you for being our speaker today. We thank all of you for joining What's Up Doc, my in-person attendees, and everyone that is watching this through Facebook or the YouTube channel. We hope you will be with us next month on Friday, June 11th. Our guest speaker will be Dr. Nicholas LaRochelle. Dr. LaRochelle is the medical director of the emergency department, and he will be talking about acute stroke care. We wish everyone a wonderful weekend. Thank you.
Thank you.